Okay, good morning, everybody. Thanks again for your patience while we figure out this technical difficulty we've had. I'd like to introduce our speaker for today. We have Mark Wollman, who has recently retired from the Global TB Institute. He has over 50 years of experience in TB conduct investigations and congregate setting investigations and large-scale investigations. And Mark has been nationally recognized for his expertise in TB contact investigation services. He has been part of many trainings nationally as well. So without further ado, I'm going to share my screen and have Mark take over. Okay, can everybody see the screen?
Yeah.
Okay, perfect. Mark, over to you.
Is that going to be full screen? There you go. Good. Good. And I can't advance, correct?
That is correct. You say next and I'll advance it for you.
All right, thanks. Thank you very much, Shweta, and hi, everybody. Sorry for the delay. So I understand this group consists of many new and inexperienced TB staff. So this is a great opportunity really for some review of the fundamentals of contact investigation. So I'd like to first start out with some few background slides before we talk about some of the more basic fundamentals. Next slide. So whenever I talk about TB and contact investigation, sometimes I like to start out with this slide, the essential components of a TB control program. If you look at the slide, I've listed hopefully most, if not all, components that make up a TB program. And so I believe that if every one of these individual components is effective, then the program itself should be effective. But if one or more of these components becomes ineffective, it could have a ripple effect, a negative effect on the program itself. Next slide, Sweta. So people who know me know I'm an advocate of a well-trained, skilled field component. And in this component, I feel probably nationally, most contact investigations are initiated, conducted, and evaluated through this component. I do believe if this component fails, it could have a negative effect on the entire program. So having said that, you can advance, Shweta. That's a good lead into just discussing some of the priority TB control prevention activities. So number one, identify and treat persons who have active TB disease or any form of disease, pulmonary or extrapulmonary. Number two, locate and evaluate persons who have been in contact with infectious patients or potentially infectious patients. I say potentially because some patients are smear negative, but they do have the ability to transmit, so they're potentially infectious. To determine if they're diagnosed with latent TB infection or TB disease, and of course provide appropriate treatment to completion of therapy, which is not just starting people on therapy or for LTBI or TB disease, make sure they complete therapy. And number three, use targeted testing strategies to identify and treat persons with LTBI at risk for developing active disease, including, of course, close contacts, persons with medical risk factors and/or social risk factors such as homelessness or drug use, recently arrived immigrants within 5 years from TB endemic countries, and healthcare workers serving high-risk clients. And finally, number four, identify settings that have a high risk of transmission for MTB and apply infection prevention measures, including all congregate settings such as correctional institutions, long-term care facilities, and shelters for the homeless. Next slide. So the purpose of the contact investigation is quite simple: identify all high and low risk contacts who have been recently exposed to an infectious or potentially infectious TB patient. I highlighted recently because we're going to talk a little bit about the infectious period later on. So we want to only identify contacts during the infectious period, not prior to the infectious period. So a contact investigation should not be regarded, this is my personal opinion, should not be regarded as a general screening activity where large numbers of people are unnecessarily tested, but rather it's an activity focused only on the testing of contacts who identified during the infectious period. And I always believe that the wider you cast a net to identify who you think are contacts, the more likely you're going to find remote infection. So bigger is not better when you do these contact investigations, particularly congregate setting investigations. If there's a way to really work on identifying those who have the closest, and more intense exposure rather than casual exposure, those are the ones we're looking for. And we'll discuss that also as well when we talk about the concentric circle model. So again, it's an activity that is not focused on just testing anybody. It's a very focused activity, and we're looking for those recently exposed to test them, and not the low risk or not even the worried well, of course. Next slide. So the objectives of the investigation, again, medically evaluate all appropriate contacts who were recently exposed, identify contacts recently infected and diagnosed with LTBI, and certainly provide appropriate treatment to completion of therapy, thus preventing future disease. Always remember, I'm sure you've read this before, all TB cases began as TB contacts, and lately I've been saying all TB cases began as LTBI. Identify contacts diagnosed with TB, and by the way, that's the reason why, of course, if all contacts did start as LTBI. Could have been a year ago, could have been 20 years ago. That's why it's important that if you identify someone recently with LTBI, it's so important to get them on treatment to completion of therapy. Identify contacts diagnosed with disease and provide appropriate treatment to completion of therapy, thus preventing further transmission, of course. And finally, identify contacts at high risk of developing disease, such as children, immunocompromised, and provide appropriate treatment until infection and disease is ruled out. Next slide. So summarizing the importance of conducting these contact investigations, number one, we identify new cases of disease or LTBI. It ensures appropriate initiation of treatment for TB disease or LTBI to completion of therapy, interrupts the spread of TB, and prevents TB outbreaks. That's really the importance of conducting investigations. Next slide. So a quick word about the responsibility for conducting investigations. State and local health departments do have the legal responsibility in their particular jurisdictions to oversee and monitor TB surveillance activities, to conduct contact investigations, and evaluate the effectiveness of TB investigations. Some of the investigations may require, may be delegated to other resources, such as if you're doing an investigation in a hospital, you may tap into the infection control practitioner or the administrators to help you decide who really was exposed to this particular healthcare worker or patient. And finally, CDC only provides guidance and recommendations to TB programs and may, however, if requested, provide on-site presence during an investigation. So if your site or your program is involved in a major investigation where there's numerous contacts and you're seeing transmissions, particularly to children or to anyone, high risk individuals, and you think that your program needs help during the investigation, CDC certainly is willing to provide that on-site presence and assist in the investigation. But primarily their goal is to provide guidance and recommendations. And the most recent recommendations that we use was 2005 NMWR guidelines for contact investigations for infectious TB patients. It's outdated. I'd like to see them renew or revise their guidelines, but that's the one that certainly is in publication right now. So if you haven't read it, it's a good idea to kind of browse through it. Next slide. So just quick definitions. Index case, as you know, represents the first instance or initial report of TB disease. A source case represents the original source of infection or disease. And a very basic definition of contact, anyone exposed to MTB by sharing airspace with a person with infectious or potentially infectious TB. Next slide. So a definition of a contact investigation, an activity for identifying people exposed to an individual with infectious or potentially infectious TB, locating and evaluating them for latent TB infection and disease, and providing appropriate treatment to completion of therapy. We already covered that in the previous slide. A source case investigation is a contact investigation in reverse. So we'll take a look at that. Next slide. So in a contact investigation, you can advance, Shweta. A contact investigation, you start with the index case, could be a confirmed case or a presumed case. And the whole idea of the interview and the investigation is to look for transmission. Advance. Through the transmission, we're looking for, well, the transmission result in LTBI or TB disease. Perhaps we can find a secondary case. A source case investigation really is as I mentioned in the previous slide, a contact investigation in reverse. So with a source case, we already are working with, we know transmission occurred. It's either LTBI, TB disease, and typically a source case investigation starts around young children, and CDC does recommend 5 years of age or less child with any form of TB, whether it's pulmonary or extrapulmonary, if you have the resources to conduct a source case investigation. Typically, as you may know, typically someone that young, it's usually someone in the home that is sick and undiagnosed. Maybe they think they have pneumonia or the flu, bronchitis, but typically it's someone very close to the child. And also we do source case investigations on children who are 2 years of age or less who are diagnosed with LTBI. So again, if you have the resources, we recommend, CDC recommends that you do a source case investigation around those children, because typically it's someone in the household or very close to the child. Clearly they're not working. They may not go to school. It's usually a family member, an older sibling, a visitor, childcare, someone who has flu-like symptoms. And again, if you have the resources, CDC does recommend do a source case investigation. So as a result of investigation, we are looking for the index case, just the opposite of the contact investigation. We start with the index case there. A source case investigation, we end with the index case if we're lucky enough to find the index case. Okay, next slide. So the question is, who are TB contacts? So you have household, you can keep it advancing. You have social, we have work-related, we have houses of worship, we have shelters, correctional facilities, and healthcare workers. So TB contact can be any one of these, and I don't know if we're missing anything, but these are probably the major categories. So we're not, I think a mistake that some interviewers make, as I've learned over the years, is that sometimes interviewers who are conducting investigation, when they speak to a patient, they focus on the household contacts. And so we have to be careful that someone may name household contacts, but there's other contacts out there during the infectious period that we need to explore. And typically they're social contacts. It could be school contacts, work contacts, of course. So just keep that in mind, that it's not just household contacts. We have to ask the patient about all the people they associated with during their infectious period. And then we'll decide later on who's high risk, who's low risk, and who's worried well. Next slide. So I guess a question for the group. I think the group today is representing many different programs throughout the East Coast. The question we usually ask is, when we do this in person, how do you think we're doing in contact investigations? This is a 10-year look from CDC, from the aggregate reports that are collected across the country. It takes about, the last year recorded was 2020. It takes about 3 years for CDC to collect all the data on contacts. So that's the most recent numbers that we have. I wouldn't spend too much time on this, but I do like these slides because it does tell us how we're doing. So the top line represents number of cases reported year by year. Every time a new year is reported, I drop the previous year. So I always keep this 10 years. So this is 2011, 2020. So number of cases reported, you can see there's been a slight decline, although I'm told the last year or so, we've seen a slight increase, of course. 9,000, I think it's 9,000 cases now. The second line represents of those in the first line, who, by the way, the first line represents pulmonary and extrapulmonary, all cases. The second line, sputum smear positive, clearly represents those who are pulmonary. So you can see that the range is 3,000, 2,000 to 3,000 cases are smear positive, pulmonary cases smear positive. Of those smear positive patients, the third line is how many contacts are identified from those smear positive patients per year. And you can see the line, that averages to about 58,000 contacts during the 10 years per year. 58,000 contacts were exposed to a smear positive patient. Basically, that's what it comes down to. Next line down, contact index, that measures the number of contacts per case. So you can see the range is 21 all the way down to 14 or so, or 12. I personally think that if a contact index in your area is, go back, Shweta, a contact index is a 20 or 21 or 18, I think it's kind of high unless you have many congregate setting investigations where you go to high schools and colleges and workplaces and shelters and jails. I think across the country, I think the number of 10 contacts per case is probably reasonable. New Jersey hovers around 9 contacts per case, and some of the states in the East Coast are about the same. So I think when you go back to your sites, I think you might want to ask your management team, what is our contact index in our state, in our county, in our region that we provide TB services? Because if it's 21 or 20 or 18, I'm not saying it's wrong. I'm just saying check into it. Make sure that the interviewers are not just collecting anyone, worried well, low risk. We want to make sure we're getting the right number. Likewise, if your contact index is 1 or 2, that's probably too low. That probably indicates the interviewers are not getting enough contacts. So it's just a barometer to see how the program is doing. Again, I think 10 is probably reasonable. So just keep that in mind when you go back to your sites and just find out what the index is in your area. No contacts identified. Nationally, it hovers around 5% for many, many years. There was a little blip there on 2011, 12%. That's rather high. But typically, it's always been 5 or 6%, meaning cases had named 0 contacts. They live alone. They don't have any social contacts. They keep to themselves. So that stays pretty much the same. However, number evaluated. So if you go back to the third line where number of contacts identified, as I said, the average is about 58,000 if you average all that up. So how many were evaluated? So the national objective, you can see in the right-hand corner, is 93%. That's what CDC would like us to strive for. Those numbers across the board are about 82%, I believe. So we fall a little below 93%. Not evaluated, next line represents about 18%. So the question is, what, if you look at the numbers, it's like 8,000 to 13,000 contacts to smear positive patients that we lost, that weren't evaluated. So that's not good because they represent future disease, perhaps. So why are so many people not evaluated? Well, there's 3 reasons that we can come up with. There might be more that you could think of. One is they can't be located. Number 2, they maybe live in states where there's no legal mandate to have contacts evaluated. New Jersey is one of, I believe, 16 states in the United States that can mandate contacts once they're located. No contact in New Jersey can refuse to be evaluated for LTBI and/or TB disease. Of course, they can refuse treatment for LTBI, but they can't refuse to be evaluated to rule out disease. So only 16 states that I can recall, we did a survey several years ago, unless more have joined. So we think that some of these contacts who weren't evaluated are living in states where they can't be mandated to be tested, which is a shame. I really think every state should have a legal component mandating contacts to be tested, at least to rule out disease. The third reason that maybe we are not seeing contacts is because maybe some of these contacts were tested partially. Maybe they received their initial TST or IGRA, but didn't come back for post-exposure testing, which is important. So perhaps CDC is counting them as not fully evaluated. So those are the 3 reasons that we've come up with as to what happened to these thousands of contacts who were exposed to smear positive index case. TB disease line, it's pretty solid, about 1% across the board of all TB contacts that were evaluated. About 1% developed TB disease. So it's if you have 58,000 on average, 58,000 contacts that, let's say, that were evaluated, 1% is a lot of contacts who became cases, like 500 cases. So it's important to know that contact investigations is an important activity, not just for identifying LTBI, but also it's an activity that helps to actually have a good yield of finding new cases. So another reason why the work that we all do in the field with these investigations is very important. You can find new cases through contact investigations, contacts who were diagnosed with TB disease. LTBI treatment initiated, the national objective is 91%. You can see that we're not even close to that. Up until 2020, we're only averaging in the 70 percentile for treatment initiated for those who are infected. Treatment completed is actually much better. The goal is 81%, and as of 2020, we're at 79%. So we're getting much better, and obviously the reason why we have short-course chemotherapy. When it was 6 to 9 to 12 months was very hard, as you can imagine, for patients to complete therapy, because obviously some of the LTBI is asymptomatic. They feel they are healthy, basically. And to get them to finish treatment was really a challenge. And now with 3 and 4 month therapy, it's becoming easier for the patients. And what's more important is that they're finishing their treatment. And obviously, if they finish their treatment, it greatly reduces the risk of developing disease later in life. Next slide, Shweta. So I'm sorry, so that previous slide was smear positive, culture positive, and this slide is smear negative, culture positive. I'm not going to go through, it's the same categories, but the numbers are smaller. I think the caveat here is if you look at, can you go back one slide, Shweta? If you look at the line for infected, 19% all the way down to 14%. This is important. The transmission rate from case to contacts ranges from 11 to 19%. So for contacts to smear positive, culture positive, the range of infection is from 14 to 19%. And the next slide, Shweta, the transmission rate is 11 to 18%. So I think the message on this slide is that even though the numbers are smaller, the number of smear positive patients is smaller, or smear negative patients is actually larger. The point is that someone who's smear negative, as I mentioned earlier, does have the ability to transmit. Now, we don't know if these numbers are really 100% accurate on the infection slide, on the section, the row that indicates infection, because some people may be remotely infected and they have no documentation. Or maybe they were infected 10 years ago and didn't know it. But anyone who comes forward as a contact, if they can't provide documentation, they were previously positive, they are tested, and if they're positive, they go down as recent transmission. So we hope these numbers are accurate, but you can see where smear negative patients do have the ability to transmit, and that's the important thing to remember when you do your investigations. Don't disregard, don't put too much emphasis. Oh, well, they're smear negative, I don't have to do that much of a contact investigation. No, you need to do a good investigation, whether it's smear positive or smear negative, especially if someone's smear negative with cavitary disease and a cough. You need to assume that they're probably infectious. And the same thing with LTBI treatment. We're not reaching the national objectives. 91% for initiation. We're not even close to that, and we're getting a little close to the completion recommendation of 81%. We're getting close. Actually, in 2019, we hit that 81%. So again, during investigations, if your health department or clinic diagnoses someone with LTBI, it's really important that we stress the significance of taking the treatment, preventive treatment, to prevent disease later in life. Okay, next slide. Some priorities we're going to talk about. Initial interview. CDC initially recommended that TB interview should be conducted within 1 business day of case report for infectious patients and 3 days for those who considered non-infectious. We think that the 1 day was rather not practical, because many programs have staff members, nurses that do lots of different diseases, not just TB. So we think that within 3 business days, all patients who require a TB interview should be interviewed, and the process should begin within 3 business days. The re-interview is something that we borrow from the STD program. So we believe that about a week to 14 days after the first interview, a re-interview should be done, the index patient. Ideally, 1 interview should be conducted in the living space of the index patient. Unfortunately, some patients are in the hospital for many weeks, maybe a month. So the re-interview can take place in the hospital, but after the patient's discharge, 1 interview should be conducted again in the living space of the patient, just to make sure that what we're being told is accurate, especially if the patient says, well, I live alone, or I live with my partner. We don't have any, there's no children there, but then you go and you see children's toys, children's shoes, pictures. So it's a good way to kind of just confirm what the patient is saying. Okay, next slide. The infectious period, very important, establishes the probable date, a start and end date of potential transmission. It's not determined with precision. It is an estimation. It's not a scientific method. It's an estimation of someone's period of infectiousness. It does bring focus to the interview, and I believe you can't or should not conduct an investigation without it. You need to always establish an infectious period. It may not be perfect, but you need to give the patient parameters to think about the identification of contacts. Next slide. So this is a table that's put together. It was also in the NMWR, put together that we are currently revising. There's a couple of things on here that we would like to change. It's a little confusing, and it's out of sync with some other recommendations from CDC, so we're taking a look at it. Basically, for those who are not familiar, you're going to find the first abnormal finding consistent with TB, whether it's a positive smear, an abnormal X-ray, a cough. You're going to find that abnormal finding and the abnormal film, of course, and you're going to go back 3 months prior to that start. So if someone says, I'm coughing for 2 months, you're going back 3 months before the cough started. If someone has an abnormal X-ray today, you're going back 3 months prior to the X-ray, and the same with the smear, going 3 months back. The typical infectious period is 3 to 4, maybe 6 months. CDC doesn't recommend going back anywhere past a year, if not, I mean, there are exceptions, but the further you go back, the more difficult it is for patients to remember what they were doing, even with the use of, social media. But typically, an infectious period is about 90 days prior to the first abnormal finding. So I'd like to spend more time on this table, but since we do want to revise it, I don't want to give out misinformation. But the basic premise is 3 months prior to the onset of the first finding consistent with TB disease, whichever is longer. And we can talk a little more about that, I think, later on. But any questions about that, please chat it in, and we can talk about it, because this is a very important part of contact investigations. The one-on-one interview with the patient, you must establish an infectious period, because that really keeps you as the interviewer focused, and it certainly gives focus to the patient, rather than saying, so tell me who you've been living with, tell me who you've been socializing with. That's too vague. You have to say, from May 1st until last night when you were admitted to the hospital, I want to know everything about your life, where you live, who you socialize with, what school you go to, where you travel, doctor visits, during those time periods. Not before, all right? It's May 1st, for instance, May 1st till last night. Let's talk about that time period only. And it gives focus to the patient, and the patients sometimes really need that focus. Okay, next slide. So ending infectious periods are a little different, can be a little trickier. Historically, we always felt the patient's infectious period ends with effective treatment for at least 2 weeks and improved symptoms, particularly cough, and a response, a bacteriologic response. So for instance, 4+, 3+, 2+, 1+, or many, few, rare. But in the last couple of years, we've been doing something a little different, because the infectious period really only ends. The biological end of the infectious period is when you have 3 negative smears. That's the official end of the infectious period. But for purposes of contact investigation, we can use effective isolation as ending the exposure period. So if someone is admitted to a hospital, let's say today, and they're placed in airborne isolation, that's effective isolation. If you want to go back 3 months prior to, if your start date is 3 months prior to today, then you can say, what is this, August, so June, or May 1st to now, you're in isolation. Let's talk about who you spend time with. We're not going to know when that patient's going to have 3 negative smears. It could be weeks or months down the road. So again, for contact investigations, when the patient is effectively isolated, you can end not the infectious period, but the exposure period. And then you can focus that period of time on identifying contacts and the lifestyle of the patient. And of course, nothing changes, at least nothing's changed recently, I don't think. A patient returning to a congregate setting should have 3 or more consecutive negative sputum smears. However, I'm hearing with the new guidelines that have been put forward about releasing patients from the hospital after 5 days, I'm not so up on it. I have to read on it a little bit. I was told about this a few weeks ago. It would seem like I would be very reluctant to allow a patient who was only on treatment for 5 days back to a congregate setting unless they have 3 negative smears, particularly a school, workplace, a shelter. correctional facility. So I'm not sure what the guidelines say about that, but I need to learn about it. So, but anyway, so the important message here is the infectious period doesn't really end until you have 3 negative smears, but the exposure period can end when you have effective isolation for purposes of the investigation. Next slide, Shweta. I think the challenge in contact investigations sometimes is to not only identify the contacts, but prioritizing the contacts. Who really is high risk? Who's low risk? Who needs to be tested first? What do we look for? So I have four categories: person, place, time, and contact. So person characteristic refers to the index case. That refers to bacteriology results. Is the person smear positive or smear negative? X-ray results, is it cavity, no cavity? Symptom history, is there a cough and no cough? Those are things we look at for the index case. For the place, we look at the environment of exposure. Where was this exposure with this case? Was it in a big open space like a warehouse of hundreds of thousands of square feet and good ventilation, or was it a small, poorly ventilated, crowded classroom or workplace? What was the place, the environment of exposure? Then we look at time. How much exposure was shared in this place with this person? What was the duration and frequency of exposure? Was it a one-time exposure for a few minutes, or was it several hours a week or an hour a day? Those are things we look at. And of course, most important, we look at the contacts. Who are the contacts? Are they infants, children, elderly, immunocompromised, immunocompetent? What's their lifestyle? What's their risk factors to develop disease if infected? So these are things we look at, and you can start with the contact and cascade up, or start with the patient and cascade down. But these are the things we look at, and I think there's lots of emphasis on, well, if someone's smear positive, we're going to test a lot of people. But someone who could be smear positive could also be, as I mentioned earlier, in a huge space with plenty of ventilation. Maybe contacts don't have to be tested, or maybe contacts don't have to be identified. So I think the next slide, we have a couple of examples, Shweta. Yeah, so investigation A, we have an index case with 4+ or many on AFB. Final ID pending. We could say PCR and NAT is positive now. Cough for 2 months, cavitary disease, diagnosed with presumed pulmonary TB, placed on the 4 drugs. During the infectious period, the patient was employed full-time for 40 hours. He was a warehouse laborer, had multiple tasks. So one day may unload trucks by himself or herself, and the next day load trucks. The next day maybe move packages around the whole warehouse. Every day, different assignment. Really wasn't assigned to a team, just individual working. Warehouse measures about 240,000 square feet, ceiling height 75 feet. So point of reference, that's big enough to fit an airplane, at least one airplane in there. It's very huge. Adequate ventilation, all breaks inside, outside the warehouse. There was a break room, but patient did not use break room. Outside the warehouse, there were lunch trucks and picnic tables, and that's where this patient every day had lunch. So we look at this and we say, well, this person is 4+, does definitely have the ability to transmit cavitary disease, coughing. So the question is, are you concerned about the 20 coworkers? Investigation B, index case is 2+. Also could be NAT positive, cough for 2 weeks, non-cavitary disease, presumed pulmonary TB, placed on treatment during the infectious period, employed part-time 20 hours a week rather than 40, was an office worker, had multiple tasks, shared an office with 5 coworkers in 600 square foot room, which is about the same size as a typical classroom, ceiling height 10 feet, pretty decent ventilation, all breaks also taken inside outside. So the question is, if you had to pick one on a particular day, what investigation would you pursue? So again, no right and wrong answers here because everyone makes their own decisions. But I would lean towards the office worker, probably a little less infectious than the 4+ patient, but I'm more concerned about the environment. 5 people in a room, 600 square feet, low ceiling, or 10 feet is a typical ceiling. I would be concerned about potential transmission there. So I would do that investigation first. And at the investigation A, unless there was if the patient used a break room, I'd be more concerned about that. I've done investigations in these types of warehouses where a break room is available. And the few I've done, they're crowded, low ceilings, no ventilation, people smoking. I've done investigations in those break rooms because of the environment. And that's what drives a lot of my decisions when I do these investigations. I look at all the things. I look at all the things we talked about, all the characteristics, but I do focus on the environment. What was the environment? Was it conducive or not conducive to transmission? And I make a decision based on that. Next slide. The consensus circle model is a very controversial model. It's supported by many programs across the country. However, some programs don't support it. The same with CDC. There are some at CDC who don't support the model. However, there are some who do support it. It does set the parameters of the investigation. It defines the limits of the investigation. It does allow the investigation to proceed in an orderly fashion. It's really a methodology designed to assist in visualizing the work that has been done by the investigators in the prioritizing of information collected of identified contacts at risk of exposure, which includes the probability of transmission, person, place, and time characteristics, and the risk for progression to disease, contact risk factors. So next slide. So this is a diagram that I used. If you look it up, there's many different diagrams you could use, but they're all basically the same. This was a theory that was developed in the 1960s, I believe, in, I think, Belgium, I'm not sure. And they called it back then the stone in the pond principle. You throw a stone in the lake and all the ripples come out. So the concept here is that in the middle, you have the index patient, and every circle outward represents a level of exposure to the index patient. So the middle ring would represent, because TB is typically spread by close, prolonged, intense exposure, the middle ring would ideally represent household contacts, close social contacts, perhaps contacts at a congregate setting, such as classmates, co-workers, things of that nature, who have the most exposure. They go in there, and every ring outward represents less and less exposure. So if you look at the bottom right-hand side, it's less time plus greater distance equals a lower risk in patients without medical risk factors. So if you determine that someone had minimal exposure, but has a medical risk factor, you could move them into the inner circle. You just have to know about that person. So here you have the whole idea is this circle doesn't do the work. The investigator does the work. You go, and primarily this is the congregate settings. You go out, you identify who you think are high risk, or you identify all the contacts, and then you figure out who's high risk, who's low risk, based on the hours of exposure, the environment, and you can put their, if there's not too many, you can put their names in the circles, or you assign each name a number as a code, and you put the numbers in the circles. And so you begin testing the inner circle first. And if you see no transmission in the inner circle, the thinking is, why test people in the outer circle if they had less exposure? The danger is that you could miss someone at that outer ring there. Someone could have very little exposure to index patient, but maybe they're diabetic or HIV positive, immunocompromised for any reason. You may miss them because you were told that person didn't spend much time with the index patient. So again, if you find out about the medical risk factor, you do have the ability to move them to the inner circle. So every state, every program has a cut point if they use this model. So the question is, when do you expand? So if you have 100 contacts and obviously no transmission, well, then you can eventually close the investigation after post-exposure testing if no one converts. However, if you start seeing transmission, at what point do you then go, okay, I can go to the next circle? I have I have 20 people here at the next circle. Should I go to them? Well, your program really should decide what cut point that you would use. In New Jersey, years ago, it used to be 15%. I think now it's 25%. But whenever I do these investigations, I'm always thinking circles, right? When I'm walking around, I'm drawing diagrams. I go to a school or workplace. I'm always thinking who's going to be the inner circle, and I want to save some for the outer circle in case I see transmission, rather than test everybody all at once. CDC recommends you start with the high-risk contacts first, and only advance or progress to low risk if you see transmission. CDC does not recommend testing high risk and low risk together. They like you to do it step-by-step process. And then, so as you expand, you stop testing as you see no more transmission. So if you have 20 people, or say 100 people in the inner circle, and 25 are positive, and you have another, let's say 50 in the next circle, then you can go to that circle if you think that that meets your state's criteria. You may have another, say 15 in the outer circle, but if there's no more transmission in the second circle, you can stop testing. That's what the model dictates. All right. So it is controversial. I use this all the time when I go to workplaces and schools and settings where there's hundreds or thousands of people, because it does help me sort things out. I have to do the work, and you'll have to do the work, but then you just use this as a visual of the work you just did, and then it helps you decide who needs to be tested and who can wait to be tested. But again, it is controversial, not everyone buys into it. But I've used this for all the years I've worked in TV. I've always used this in congregate setting investigations. Next slide.
Mark, before I move on, there's a question or a comment in the chat by Richard Smith. 3 negative smears collected on 3 consecutive days, or 1 collected every 8 hours. Could you please clarify?
The recommendation has always been 1 every 8 hours, right? But there's always flexibility. I mean, we've had cases in the past where we didn't get 3, we got 2. We got 2 in one day, 1 another day. As long as you have 3, but the CDC does recommend 1 every 8 hours, which can work for some patients, but maybe not all patients. The goal is to get at least 2, if not 3 negatives within 24 hours anyway. That's what I think. Is it okay?
Yep, thanks, Mark.
Was there another question?
No, there was a comment by Kate that my understanding is new guidelines are not congregate settings.
Yeah, I wasn't sure, Kate, because it was brought to my attention about a month ago, and I didn't do enough reading on it. But I know that it's not, if I'm not mistaken, it's not mandated yet. It's up to each state program to decide whether they want to adopt these recommendations. I don't think CD fully supports it. That's what I was told. But I do know some states, effective July 1st, they started to adopt these guidelines. New Jersey, to my knowledge, has not adopted them. New York City, I think, has. I heard that just the other day. I'm not really sure. Yeah, so it doesn't refer to congregate settings. I'm glad to hear that. Although I have to say, I did hear a couple of days ago that I wouldn't mention the program. They were allowing a patient after, I believe it was less than a week treatment, I think, to go back to a shelter. And so I'm not really sure what the smear results were or the NAT results were, but I don't think the patient was, if that patient was in New Jersey, we would not have allowed that patient to go back to a shelter. So I'm not really sure what programs are doing now with this. I think it's a little confusing. Yeah. Anything else, Shweta?
I think there was one more question. Maybe we could save that question at the end. I just want to make sure we get through the slides first.
Okay, sure.
Okay.
So just to talk a little bit about contact investigations beyond congregate setting investigations, expanding investigations, and outbreaks. Next slide. So a congregate setting is an environment where a number of people meet or gather and share the same space for either a limited or extended period of time. Next slide. And these are some of the more common sites that not just New Jersey, but programs across the country are involved in, all levels of schools, elementary, secondary, colleges, and universities, daycare centers, houses of worship, not just the traditional cathedral type houses of worship, but storefront houses of worship. And some people don't know what that is, but storefront houses of worship are just what it sounds like, a store, a retail store that was converted into a house of worship. And so we've been involved in several houses of worship investigations, perhaps this group has as well. Whenever I hear a patient attended a storefront house of worship, to me, it's a red flag because these houses of worship, these storefronts will pack in on Sunday or in services, they'll pack in 100 people in a little less in a tiny space. And so to me, that's, represents a environment of exposure, of transmission. Hospitals, other healthcare facilities, shelters, correctional facilities, certainly workplace settings, social settings like taverns, bowling alleys, things like that. These are typical sites. Yeah, you can go next slide. So congregate settings of interest by age group during the infectious period. For adolescents, there'll be houses of worship, any kind of travel. These are questions we need to ask all the patients. These are some of the questions. Any medical, hospital visits, workplaces, what schools they attend, juvenile detention centers. For adults, same thing, house of worship, travel, medical, hospital visits, work, school, any shelters, prisons, drug treatment centers. And the elderly, houses of worship, travel, medical history, a medical hospital, work, shelters, prisons, long-term care facilities. These are just some of the questions that as interviewers we need to ask patients where they spent their time during the infectious period. I've learned over the years, and you either have or will learn, that if you don't ask a TB patient a direct question, you're not going to get an answer. Sometimes patients only answer vagueness. We have to be direct with patients. We have to really we're not interrogators, but we need to very direct with patients and not just rely on patients, just telling us what they want to tell us. We want to make sure we ask the right questions and ask it the right way, open-ended questions. Next slide. So when to expand a contact investigation, CDC recommends achievement of program objectives with high-risk contacts first. All right, so before you expand, how'd you do with the high-risk contacts before you go to low risk? That's what they want. We're looking for extent of recent transmission and contacts, such as unexpected high rate of positive TST or IGRAs, evidence of secondary cases or transmission to contacts age 5 or less, documented conversions of TST or IGRAs, and for those who are using TST, change in TST status from negative to positive. In absence of recent transmission, investigation should not be expanded. CDC is very firm on that. They don't like to see expansion of testing without a rationale, and the rationale is, well, I'm seeing transmission in the high risk group, so that's why I went to low risk. So that's something always to remember. Next slide. Some of the challenges in these congregate setting investigations, depending on the setting, these are some of the challenges: potential for a large number of identified contacts, potential for vague information, for determining contact priorities, potential for incomplete identity and locating information, challenges in maintaining patient confidentiality. I always think, we go out of our way to protect the patient's right to medical privacy, but patients, they can tell everybody. If they're a hospital, they pick up the cell phone, they tell their coworkers, they tell their friends, but we go out of our way to protect their confidentiality. Collaborations with officials and administrators who are unfamiliar with TB, and media coverage. Actually, we like media coverage. We really do. We've always felt as if it was good to keep TB on the front pages of news media. But of course, we prefer that coverage to be educational, not breaking patient confidentiality of printing the patient's name, which has happened to us in New Jersey, perhaps other places as well. The collaboration part is one of my favorites, because when I've done investigations, I've always dealt with people who were trying to tell me what to do. Well, 300 people work here, I want them all tested. No, that's not what we do, and I explain what we do. I always felt as if that someone could be successful in their field, their career. They could be in charge of a law office. They could be a president of a meatpacking agency or company, and they're trying to tell me how to run public health. They're trying to tell me how to proceed in this investigation. So it is a challenge. I've never succumbed to the wishes of people who demand things from me. What I've learned over time is that I do the best I can to explain things. When I see I'm reaching a wall, I carry with me a color copy of that concentric circle model. I take it out of my briefcase and I say, this is what I'm talking about. This is what we do in TB. We start small and we only expand if we see testing. And my experience is that when they see that picture of the model, it's so much better than me talking for an hour about it. I just show them a picture and they get it. So, for those of you out there who want to try this model, who support the whole concept of the model, keep a copy with you. When you go to meetings with management, whether it's a workplace or the dean of the college or a principal of the school, take that with you, because they may try to pressure you to test more than what you want to test. So you need to stand firm. You're the expert in TB, and this is what we do, and that's what I've learned over time. If you go to a large workplace, sometimes it's difficult to determine the contact priorities. I remember once I did an investigation in a shoe factory, and the patient told me that he worked on a assembly line putting heels on shoes. That was his job. And then when I went to meet management and they took me on the walk, and by the way, in New Jersey, we can reveal the patient's identity if they give us written consent. So we always reveal the patient's identity. Patients usually always sign giving us written consent that we can reveal their identity and diagnosis to the workplace or the school. And we have a form for management to sign that if we reveal the patient's name, they will protect the patient's right to medical privacy. So once all that's signed, everything's out in the open, we can talk about the patient. And so when I went to meet management, they took me on a tour of the facility, and they told me, well, yeah, one day a week, that's what this patient does. But then the other day, maybe on a different assembly line. Another day, maybe unloading trucks or loading trucks. So the patient didn't tell me that. So sometimes it's hard to figure out what the priorities are. And sometimes we test more than we want to test. But the idea in these congregate investigations is do the best we can to limit the testing to those inner circle people and keep names handy for the outer circle in case you want to expand testing. But that is the challenge I found in these investigations, is prioritizing the contacts. That's the big challenge. And it's not a perfect thing that we do. It's really not. It's sometimes it's a gut feeling that we have. Yeah. So next slide. Outbreaks are defined as meeting the following criteria: 2 or more contacts are identified as being diagnosed with active TB, or any 2 or more cases occurring within a year of each other that are discovered to be linked through genotype linkage. A TB outbreak is indicative of potential extensive transmission and applies after there's an undiagnosed, untreated, contagious patient that may be in the community. Index patient may have multiple exposure sites. Environments of exposure may be promoting transmission. And the one I think is probably the most important, a substandard contact investigation and follow-up may be responsible. And that's our job. We have to make sure that we do a good contact investigation. We ask the right questions. We collect the right information. We don't back away from the patient. We have to collect all the sites of exposure and follow up and determine whether any contacts need to be tested. So we don't want to be held responsible for a substandard investigation. Let the patient hide information from us, but we need to do the best we can to get that information from the patient. Next slide. Oh, do we have time, Shweta, to do a case?
Sure, we can do one case. Yep. Okay.
So this is an investigation I did on a college campus. Sometimes when we do these investigations, we're thinking, well, who am I going to end up testing? Everybody, a big group, a small group. We never test everybody, but I'm just saying that's sometimes what we think. Who are we going to test? How many people? So when we enter an investigation, this is what we're thinking. And then especially a college campus or high school or a major corporation. But certainly as the days go by and we collect information, our decision, certainly, comes to focus who we're going to test, who we're not going to test. So next slide. So this is a 20-year-old US-born male supervised by a private doctor, gave a 4-month history, diagnosis and treatment of allergies, asthma, and pneumonia, had cough for 4 months, abnormal film with cavitary disease, referred to our clinic. We collected sputum. It was 4+ on AP smear. This was before we did NATs. Of course, diagnosed with presumed pulmonary TB. Doctor felt as if this patient was not sick enough to be hospitalized, so we placed him in home isolation. He was there with his parents. The parents promised that they would follow all instructions. We provided treatment through DOT, in-person DOT at the time, and subsequently the culture gram TB pan-sensitive. Next slide. So the infectious period onset date we established to be August 1st, the end date to be determined pending treatment outcomes, responsive therapy, and 3 negative smears. Index case identified 3 household and 2 social high-risk contacts. During the infectious period, index case attended a local university as a full-time undergraduate student. The exposure period, so the infectious period, it refers to the index case. The exposure period refers to the contacts during that infectious period, the exposure time. So the exposure period for potential contacts at university established from September 1st, first day of class, to March 31st, last day of class. So you can see where the social contacts and household contacts had an earlier date of exposure, and the school was a month later. Next slide. We don't have to go through this. Usually when we do this in person, we go around the room and we ask participants what they're thinking at this time. Unless you guys want to do that, I'd be glad to do it. Any interest in answering some of these? I have a bunch of questions coming up, but if you're interested, we could do it. Any interest out there? If not, I could just skip it. What do you think, Shweta?
I don't see anybody commenting, so I guess we could skip it.
Okay, so these are the questions I asked in person. Are you concerned about potential exposure and transmission to the patient, to the students and faculty? If yes, if no, please explain. If yes, what's your plan of action? Would you delay congregate setting school investigation pending outcomes of testing, results of testing and X-ray results of household and social contacts? Or would you not delay and initiate a simultaneous congregate setting investigation while contacts are being evaluated? Maybe, is anyone out there want to answer that question? Maybe an unfair question if you're new in TB, but would you wait before you go to college and see what the results were with the household and social contacts, or would you not wait and while the testing is being done, go meet the dean at the college? Any idea?
And feel free to unmute, or you can type in the chat.
Okay, well, we can just go to the next. Oh, here we go. So Anissa says, not wait, take a look at the school. Okay, I like that because that's what we did. Next slide. So as contacts, as household and social contacts were being evaluated, a congregate setting investigation is initiated at the university. I met with the dean at that particular date, and we did an on-site assessment of potential exposure environment. The dean was there. I always invite the local health department to attend the meeting as well. Next slide. So this is a question that we asked the group. As the lead person during this meeting, what specific information are you interested in collecting from university officials? Any thoughts? Like what would, keep in mind that we already interviewed the patient. So we knew what classes the patient took. By the way, I don't think I said this. Maybe it was in one of the slides. He didn't live on campus. He commuted by himself, not any teams. Kate, maybe the ventilation of the classrooms. Yeah. So yes, Kate, we're going to get to that. That's something that we're going to do with the walkthrough of the classes. I always do that. Anybody else? From Anisha, whoops. Why didn't you delay the school contact? Would it be wrong to wait for household contact results? Okay, good question. No, there's no right and wrong here. I'm glad you brought this question up. There's no right and wrong. I'll just say that years ago, in New Jersey anyway, in the 1970s and 80s, we would do that. If an index patient named household contacts, and let's say worked at the post office, for instance, the mantra back then is, why go to the post office? Let's test the household first. They had the most exposure. And if there was no transmission in the household or socials, then why go to the post office or why go to the school? There's no need. But at one point, when I was transferred to a Northern City program as a state worker, before I was married, one day I was sitting at my desk and I said to myself, there are times I'm at this clinic it seems like more than I'm home. Sometimes I'm at my desk 7 o'clock in the morning, not every day, but we had evening clinics. I was after 7:30 at night and wouldn't get home till like 8:30. So I'm thinking, there must be some people out there that spend a lot of time at work and less time at home. And maybe when they come home, everyone's sleeping. So that made me think, maybe we should start doing these on-site assessments while the household contacts are being tested. Because every environment is different. So maybe the person isn't there a lot with the family, but spends more time with coworkers in a particular environment. So I thought it was worth going to assess the environment. The size, the ventilation. We're not engineers, but take a look at it. And that's when I decided to change what I was doing as a state worker. And it was pretty much, throughout New Jersey, I think they're doing that. I don't think we're waiting. Because everyone at home could be negative, but is that really a good indicator? Again, maybe not much time is spent at home. So we have to be careful who we include and who we exclude from these investigations. So from that point forward, I changed what I was doing. And I always, I would say maybe not always, but the vast majority of time, as household and socials are being evaluated and there's a potential exposure at a congregate setting, I would at least schedule a meeting, talk to management, explain the situation, maybe not recommend testing right away, but start collecting information in case I needed it, pending the results of the family. But again, you go to the workplace and you can see that an environment maybe is conducive to transmission, and you're not going to wait for the family to be tested. You're going to go ahead and recommend testing. So every case is different, every contact is different, every exposure is different. So you just need to keep an open mind. And my opinion is there's nothing, again, it's not right or wrong. There's nothing wrong, however, to going and collecting information as the household and socials are being tested. Yeah, so I'm glad you brought that up. Was there something else?
There's another comment by Richard Smith: eating pattern and establish close and proceed.
Oh, what was that, Shweta?
Eating pattern and establish close and proceed.
Eating pattern. I'm not sure what that means.
I think he just answered one of your questions earlier about when you ask about what specific information are you interested in collecting.
Oh, I see. Yes. Okay. Yeah. Okay. So, like where in this case 8, while on the campus, I guess that's what Richard means. And what was the other one? Eating habits. What else?
It said establish close. He said establish close and proceed. Yeah, I'm not sure what that means. I don't know if you want to unmute and explain further.
Close contacts. Yeah, sure. So, yeah, the patient only named, as I said, household and 2 social contacts who I believe were also attending class. Maybe not in his classes, but he was friends from school. So, yeah. So, that's some of the information we already collected from the index patient. We want to know from the university officials, is the information we have accurate? This is what the patient told us. He attends X amount of classes. Is that accurate? Did he tell us everything? And they'll look it up and say, yes, it's accurate. Those type of things. Is he on any sports? He says he's not. Is he done any tutoring? So those are things that we want to make sure the patient told us the truth. And sometimes the dean will get somebody into the meeting who maybe knows the patient and can corroborate what the patient has said, or maybe gives new information. Maybe the patient, I'll just make this up. Maybe the patient forgot to tell us that he studied abroad, for a couple of weeks during a break of some sort, during the infectious period. Maybe the patient forgot to tell us that. So we would need to know that. But yes, we want to review all information collected from the patient and have the officials at school confirm, to the best of their ability, confirm that information. Okay. Next slide. So what I found out, there's over 13,000 students that attend this college, undergraduate enrollment. In this case, as he told us, attended 11 classes during the infectious period. That covered the fall and spring semesters. There were a total of 265 students and 10 faculty potentially exposed. Typical class met 2 times a week for an hour and a quarter a day for a total of 2.5 hours per week. Next slide. So at this particular point, what are you thinking? What other information needs to be collected? Would you request additional information to better determine the extent of exposure? Kate had said, well, the ventilation of the classrooms. So we can go to the next slide. So as I mentioned earlier, when I do these investigations, I do a site visit. I make drawings with permission. You can take a picture of an environment, and you assess to the best of your ability the ventilation. Again, we're not engineers, but you can get a feeling of the ventilation in a room. And usually when I do these investigations, especially at high schools or colleges, I like to do it when the classes are empty, quite frankly, because it's awkward standing in a classroom making drawings. However, there's benefit to being in the room when people are there, especially if it's a 600-foot classroom with 30 students in it. You can get a sense, is it stuffy when it's crowded? But it is awkward standing in the middle of the classroom making drawings and trying not to be disturbing to the instructor and the students. But what I did was, what I always do, I requested a printout of all 11 classes with students and faculty names. And what I do is, like, it's just, there was 275 students and 10 faculty. But when you take a closer look at the rosters, a lot of these students take multiple classes together. And that helps me develop this concentric circle. So I'll develop a code, color code. I'll go through each roster and color, the kids different colors, and come up with a group of, let's say out of 11 classes of 275 students, I'll come up with a group of students that attended, let's say 3 classes or 4 classes, and 3 and 2 and 1 class. And then I calculate the hours of exposure for each class, for each student during the infectious period. And I come up with hours of exposure. And I come up with a concentric circle. And so the same thing with instructors, if they're in multiple classes or 1 class. That's how I do it in all these school investigations. Rather than think I'm testing 275 people, it's amazing how you can get the number down to those students who attended multiple classes and had multiple hours of exposure versus those who had limited exposure. So next slide. So exposure hours during don't forget, this is a big infectious period from the fall and spring semesters. The exposure hours range from 108 all the way down to 20 classroom hours per student. The measurement of classrooms ranged from about 400 to 1,200 square feet. Average classroom, however, was 400 to 500 square feet. Ceiling height approximately or typically 10 to 12 feet. During the fall semester, several classrooms were identified as measuring 400 square feet and did present as crowded with unsatisfactory ventilation. Felt kind of stuffy in there. Next slide. So this is a typical classroom. This one measured 500 square feet. There were 27 desks, but only 18 students, so they weren't on top of each other. A question that we always ask high school students and college students, although the answer varies, of course. Did you have assigned seating? Did you sit in the same place all the time? High school students, what I've learned when I did my investigations, for those of you who are parents or remember your high school days, yeah, you could go to a classroom in high school and have an assigned seat for maybe 20 minutes. And then from the remaining 20, 25 minutes of the class, maybe you get up and you do group work, and everyone moves around. And so, and sits at a table. And so it's almost irrelevant where they were sitting. So in those instances, you may want to test the classroom, of course. In college, there's no assigned seating, but we asked the patient, did you gravitate in any particular seats in the classrooms? And he said, no, I just sit wherever. I don't know who I was sitting near, one of those things, because we're hoping to maybe identify some people that he spent time with in classroom, but he wasn't able to do that. And you can see this was in a modern building. There were windows, but I don't think they opened in this particular building. Okay, next slide. So what are your thoughts now? These are what we asked the participants. Is there any information you feel needs to be asked? I'm just reading this chat. There's specification of the living space. Well, good question. No, that's the thing about the work we do in these investigations. There's very little guidance. It's sort of like I told someone yesterday that it's like every time you do one of these investigations, you learn how to do the next one. And because there's no like golden rule here. A lot of what we do is gut feeling, trying to avoid over testing, trying to identify the right people to test. There's no specifics. Obviously, the smaller the environment, the more aware we should be of potential transmission rather than the larger the environment. And to give you an example, actually, a little different than the question that was asked, is that in that MMWR, it was the only, on page 11, it was the only place I've ever seen that CDC actually mentioned hours of exposure to be considered. So if you get a chance, read it. It says for the index patient who was non-cavitary disease, 120 hours of exposure per month, could be considered as a criteria to look at. So if you break down 120 hours by week, that's 30 hours a week. And if you use 5, 6, 7 days, that could be 4 to 7 hours a day. But it's not just about hours spent. Again, it's about the environment. So you can have someone who spends 7 hours a day in that warehouse, but maybe spent an hour a day in a smaller room, and that smaller room was more conducive to transmission. So when CDC mentioned 120 hours, they said you could use these as a guide, as a criteria. But the next sentence they said, however, it also depends on the environment. So they're throwing it out there, 120 hours. I'm not sure how they came up with that, but then they're saying, but be careful because it's not just hours, it's also the environment. So just keep that in mind. So you're getting back to your question. No, there's no specifics, but again, the smaller it is, the more red flag it is, and the bigger it is, maybe the better we should feel about maybe better ventilation. But still, testing may need to be done in a large space. It doesn't exclude testing, but those are things that we look at. We can go to the next slide. So at this point, are we ready to meet with management to provide them with a recommendation regarding contacts to be tested, regarding the identification of high and low risk contacts? Slide. So these are the findings. A review of class rosters, hours of exposure, and classroom environments during the infectious period allowed for the configuration of a concentric circle, identified layers and exposure hours of students ranging from most to least hours exposed during the entire infectious period. Now, I focused on the fall semester, which is 16 weeks, versus the spring semester, which is 8 weeks, because it was 2 different classes, and there was no overlapping of students. When I bring this up, some people have said, well, why the fall semester? Why not the spring semester? I chose a fall semester because it was longer duration of exposure versus the 8 weeks. Now, some experts would say, some medical experts would say that, in their opinion, the closer a TB patient gets to being diagnosed with TB, perhaps the sicker they are. That could be true. But I chose the 16 weeks rather than the 8 weeks. Now, would you have been wrong choosing 8 weeks? No, not at all. Again, I chose duration of exposure rather than a less exposure. However, looking at the fall semester, I identified 20 students and 1 faculty member representing 80 to 108 hours of exposure and identified them as high-risk contacts during the fall semester. Next slide. So using the concentric circle model, I was able to put numbers in there of the people that I felt as if should be evaluated or potentially evaluated. So there was only 1 contact that had 108 hours, so 19 contacts had 80 hours, 13 contacts that had 60 to 68 hours, and if it had more circles, I would put more contacts in there, coming up with 275. So that's what I mean, where I did the work, and now this is the visual of what I just did. And so now the question is, what do we do? So next slide. So the outcomes revealed the following. Of the 25 total high-risk contacts identified, 3 household, 2 of the 3 were IGRA positive, placed on LTBI treatment. 2 socials were initial and post-exposure IGRA negative. Of the 21 school, that'll be 20 plus 20 students plus the 1 teacher. 8 initial post-exposure IGRAs were negative. 10 post-exposure initial TSTs was 0 millimeters. 1 was TST 13 millimeters placed on LTBI treatment. 1 we couldn't locate. They dropped out of school. There was no forwarding address. And 1 had a documented previously TST positive, and also documentation that LTBI treatment was previously completed, and they was assessed for symptoms and discharged. So we go next slide. So now we go back and put the results in, and we found that the person with the most exposure was QFT negative. Only 1 contact at 19 who had next to most exposure was TST positive. She was foreign born, and there was question whether she was previously positive or not. We had no proof, but based on what she was saying to us, we felt as if she was previously positive. And I stopped testing there. I didn't test the 13 contacts in the next ring. I didn't go beyond any other ring except the second ring. Next slide. So 1 of 18 were tested, or 5.5. Whoops, go back. 5.5 transmission rate, which is, which is nothing. I mean, it's been written that in the United States, about 4 to 5% of the U.S. population is positive on TB testing. So 1 of 18 is really nothing alarming at all. So because of that, the current setting investigation was closed with no expansion of concentric circle for contact identification. So that's an example of what I use in all, whether it's a workplace or school setting, any kind of Congress setting. I always use a concentric circle. It just helps me kind of sort things out and keeps things orderly for me, because it can be very overwhelming when you have hundreds, like 800, 700, 1,000 potential contacts. It really helps you to figure things out, and again, it's a visual of the work that you did. Nobody else did the work but you, and then you can make your decision based on what you found. So there's another case, but I don't think there's time, or is there time?
No, I think we actually went past time. So
we did. Okay.
Yeah.
Okay. Yeah. So I guess if there's any comments or questions. What do you think?
Yep. Any questions? Anybody wants to unmute and ask any questions in the last few minutes?
There was some good questions that were raised. I like them.
Okay, great. Well, thank you everybody for joining in, and thank you, Mark, for a great presentation.
Right.
As I mentioned earlier, next week will be our last session for TB 101 series. Please look out for some feedback evaluation forms that we would love for you to fill it out. And we'll see you next week. Thank you all, and have a great long weekend.
Thank you.
Bye.